Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. Today we have a common topic for women, or important topic for women. It is contraceptives, and we have invited a familiar face, Dr. Lena Merjanian. She's clinical assistant professor at Rutgers Robert Wood Johnson Medical School. Dr. Merjanian, welcome. Let's first start to say, what is contraceptive?
So contraceptives are types of medications or barrier methods to help women try to plan out their pregnancies. 50% of pregnancies in this country are unintended, so it's important for women to be able to, and couples, to be able to decide when they want to have kids.
Right. Let's categorize them. There are combination hormones, there are single hormones, and there's something that we use as a patch, something we use as pill form. Let's categorize them. Let's start with oral contraceptives.
Oral contraceptive pills are medications that include estrogen and progesterone.
Right.
There are also oral contraceptive pills that are progesterone only.
Right, they're only one hormone
Yes.
or two hormone combinations.
Yes. The same medication as the pill is also in the form of a patch, and it's also in the form of a vaginal ring that women can use. And so those are the combined contraceptive options.
There are some high doses, some low doses. Let's start with the regular high doses combination of the pills. Who are usually the candidates for those high doses, and then who are the candidates for low dose of oral contraceptives?
So generally speaking, because of the estrogen component in birth control pills, you need to make sure that the woman that you are giving the medication to doesn't have contraindications to it.
Right. So what are the contraindications? What conditions that we should not use oral contraceptives?
Because we know estrogen can increase blood pressure, if a woman has elevated uncontrolled high blood pressure, they would not be a good candidate for estrogen-containing pill.
Yes.
If a woman has ever had a history of a blood clot in her leg or in her lungs, that would also be a contraindication to estrogen.
So
clotting history. If they have severe migraines, and usually we classify that as migraines with focal neurologic symptoms. For example, if they have a migraine and they lose vision, the estrogen can actually worsen it and cause them to be at an increased risk of a stroke. And also women who have active either liver or gallbladder disease are not good candidates for estrogen-containing pills.
So it's high blood pressure.
Correct.
Clotting issues.
Correct.
Severe migraine headache, not regular headache. And then the fourth one?
Active liver and gallbladder disease.
Because they get utilized through the liver.
Yes.
Okay.
And then the other big thing that you have to think about is in women who are over the age of 35, if they are smokers, that is also a contraindication to estrogen-containing pills.
Let's talk about the patches first, simple patches first. Some women don't want to swallow pills and they would like to have patches.
The patch and the vaginal ring are basically in the same category as the contraceptive pills that are combined.
Are they combination hormones?
They're combination hormones, and so all the things that we talked about earlier in terms of who should not get the pill.
The same applies
Same
for
people
this.
for the patch and the ring. The convenience of the patch or the ring is the fact that the patient does not have to take the medication every day orally.
What are the new oral contraceptives that we have?
Not necessarily the oral contraceptives. I think one of the important things for women to be aware about is the long-acting reversible contraceptive methods.
Okay, so long-acting ones then.
Yeah, so with the long-acting methods, there are basically two categories of them. There's intrauterine devices, which are little T-shaped devices that we place inside a woman's uterus for birth control. And there's also medication that we can place under the skin in her arm.
Let's talk about first the intrauterine device, that IUD is what we call, and they are made of copper. In the past, they were made of copper.
Yeah.
What are the new ones then?
So currently on the market, there are several types of IUDs. The one that you had just mentioned was the Paragard, which is the copper-containing IUD. Now, there are also a category of IUDs that have progesterone on them.
But how about the intradermal?
And the intradermal, which is that implant that we put underneath the skin, is a progesterone only as well.
Same as the other copper one.
Correct.
Progesterone. How often it has to be changed?
So it depends on which of the methods you're using. For the Paragard, the contraceptive benefit.
IUD we're talking about now.
Yes, the copper IUD contraceptive benefit lasts for up to 10 years. The contraceptive benefit for the more common progesterone IUDs lasts for between 3 and 5 years, depending on which type you use. And the one underneath the skin is for up to 3 years.
Up to 3 years.
The advantage to all of these long-acting reversible contraceptive methods are that they're very effective. They're 99% effective in preventing pregnancy. And the reason why they're so effective is because it doesn't depend on the patient taking them.
Thank you. Because there's no missing medications.
Yeah.
So let's say a woman has IUD and wants to get pregnant. How long before that IUD should be taken off before she's conceiving?
So the beauty of the long-acting reversible contraceptive methods is that they are reversible immediately. As soon as the patient comes in, decides that they want their IUD removed, we can remove it. By the following month, they can try to get pregnant.
So then, as soon as they want to get pregnant, the IUD can be taken out. Doesn't matter with Cooper or with the medication, and intradermal can be taken out.
Correct.
Okay. So let's talk about the side effects or possible complications that can happen after the contraceptive. Let's say the woman is taking oral contraceptive and somehow has mid-period bleeding. What should they do?
So it's important for patients to be counseled on some of the side effects that are common with birth control pills. Essentially, with all the methods that we have, in the first several months, in the first 3 months, women are instructed that they should expect some level of irregular bleeding, some irregular, sometimes they have a little bit of nausea, sometimes they have breast tenderness. Those are normal. And what women will find, especially with the combined oral contraceptive pills, is the longer that they take the pills, the more regular their cycles become, the less painful their periods become, and the less amount of bleeding that they have with each of their periods.
So that bleeding will be a little less with them.
Yes.
So let's talk about the contraceptives. Besides prevention of pregnancy, what do we use contraceptives for sometimes?
Yeah, so it depends on which of the methods that we're talking about, and it really depends on which of the problems that she's having. Oftentimes, we can use oral contraceptive pills for dysmenorrhea, which is painful periods. Sometimes if a woman has menorrhagia, which means very heavy periods.
How about irregular periods?
Sometimes for irregular periods, oral contraceptive pills work very well to regulate the cycles.
For young women with the acne?
Yes, a group of patients that often present with irregular periods and some symptoms or signs of excessive male hormones,
which
like
is called androgens.
Androgens.
And do you use a little more estrogen effect too, instead of androgen effect?
Well, the progesterone actually is the part that we can play around with a little bit, because there are certain progesterones that are more anti-androgenic that may help with the acne and the hair growth a little bit better.
So then let's summarize quickly to say that we have oral contraceptives, we have patch form contraceptives, and we have long-acting ones, new ones, which is recommended now more as IUD form and the under the skin, which is subdermal.
Yes.
Okay, so which one is your really preferred method?
I think that it really depends on your patient. It really depends on what her expectations are, what her medical problems are, and really what she wants out of family planning. And so it does become a discussion between myself and the patient, and sometimes the partner does come, so that we can figure out what actually is the best method for her. And obviously we know that we still have the barrier methods that we need to think about, because the barrier methods are the only types of contraception that actually prevent sexually transmitted infections. And then the other category that we need to think about sometimes too, and it depends on the patient and the couple, is permanent contraception, meaning sterilization procedures.
Dr. Merjanian, thank you very much for this enlightening information. Hope to be seeing you in another program.
Thank you so much for having me.
Now it's time for this week's article. It is insomnia and diet quality. Insomnia affects 10 to 30% of Americans, and it's characterized by difficulty of initiating sleep, difficulty maintaining sleep, early morning awakenings, and non-restorative sleep. Insomnia is associated with several adverse health outcomes. Individuals with insomnia may have increased risk of hypertension, myocardial infarction, diabetes mellitus, and all-cause mortality. Sleep insufficiency could alter appetite hormones such as ghrelin and leptin and increase hunger sensation. Sleep deprivation and poor sleep quality increase our brain sensitivity towards unhealthy food options and is associated with greater caloric intake. Recent studies from Harvard School of Public Health examined whether individuals with insomnia had greater energy intake and a lower diet quality. More than 15,000 U.S. men aged 58 to 93 years old who were free of cancer cardiovascular disease, and diabetes participated, and their dietary intake were assessed. People with insomnia had greater energy intake and a lower diet quality. For example, they had lower vegetable consumption and higher intake of unhealthy food, trans fats, and salt. Conclusion of this study was insomnia is associated with higher intakes of total energy, trans fats, and salt, and lower intake of vegetables. To prevent insomnia and unhealthy eating pattern associated with insomnia, don't drink caffeinated beverages after 12 noon, don't exercise after 5 p.m., don't be on computer at least 1 hour before sleep. Try to go to sleep at the same time every night by 11 p.m. and wake up every morning at the same time, 7 a.m. Take melatonin and drink a glass of warm milk or chamomile tea before sleep. Good health is precious and priceless. Keep informed. Up-to-date medical information, visit AAHPO's website, aahpo.org. I'm Dr. Ohan Karatoprak. Until next program, so long.